All right, welcome back, everybody. It's been a while. I haven't been live in like 3-4 days lately because I just had a lot going on at home. But I am back. First thing I wanted to do was really just wrap up NBME 18. We finished everything up to block 3 last time. This is just going to be the last two videos for the NBME 18 playlist. I'll do the first 25 questions, number 151 to 175, and then I'll do the last 25 questions in another video and just wrap up NBME 18 so that I can keep going with the first aid videos, because in first aid videos in the full FA playlist we're up to somewhere in psych pathology, but renal and respiratory videos, even though I already have them from their own video playlist, the newer ones are going to be significantly better because there's a lot more to be taught in terms of just mastering renal and mastering respiratory, right? Because I have a bunch of x-rays, a bunch of illustrations basically for respiratory, and in renal I have many I guess really simplified and easy ways of memorizing and mastering all the ways you can get questions on renal things. We've been doing NBME 18 a lot, and we've been doing NBME in general lately, and NBMEs have brought up so many renal questions, right? They always have questions about either something related to acute kidney injury, which can then be broken down into pre-renal and post-renal azotemia. They can have acute interstitial nephritis, and everything else that's on that last page. And then, of course, just memorizing the general flow path, right? The general flow path of everything through a tubule and what gets reabsorbed and how osmolality gets mastered. So there's a lot to talk about, and I really want to finish that up. So right now we're going to continue on with NBME 18, and this is where we were. This is the first half of block 4. So let's get this going. Called missed call. All right, whatever. All right, perfect. Let's get the show on the road. So, 151. A 51-year-old woman with Graves' disease develops ulcerating pharyngitis after 6 months of daily propylthiouracil therapy. Which of the following is the most likely underlying cause of ulcerative pharyngeal disease in this patient? And then you look at your answer choices: agranulocytosis, leukocytoclastic vasculitis, thrombosis, thyroid necrosis, and TNF-alpha blockade. Okay, so this question was actually very straightforward, but they tried to make it a little more confusing by saying it's ulcerating pharyngitis. Main point here is that this patient is treating Graves' disease with PTU, propylthiouracil, and now she just has pharyngitis. Just understand that she has pharyngitis, and even if you can't really remember, it makes sense to think that there are medications that do cause agranulocytosis. It's not a very far-fetched side effect, so that was just the answer here. It's just don't get disrupted by the ulcerating aspect, and understand that she just has pharyngitis. This is simply because thionamides, like PTU, can rarely cause agranulocytosis. The only answer related to the side effects of thionamides. More common side effects are the skin rash, aplastic anemia, and hepatotoxicity. Alright, so let's take a look at that real quick. 379. Alright, so right here, thionamides, propylthiouracil, methimazole. Another big topic you can get about these is which one you can take when you're pregnant, right? So you have to remember that the way both of these medications basically work is by stopping thyroid peroxidase, right? So you can no longer oxidize iodide, right? And then that's going to stop you from making more thyroid hormone. So this is perfect for patients with any case of hyperthyroidism. One thing though is that PTU is used in the first trimester of pregnancy, right? So I always remember that because P and P. However, you can't use PTU later on. So methimazole is used in the second and third trimester of pregnancy because PTU can cause hepatotoxicity, which would really suck in your second and third trimester of being pregnant. But yeah, methimazole cannot be used in the first trimester because methimazole is actually very teratogenic. And remember that teratogenic things have a maximum potential of causing some kind of damage in the first 8 weeks because there's so much development, so much rapid development happening with the fetus early during the pregnancy. And that was actually another NBME 18 question somewhere where they asked you, right, that some mothers taking some teratogenic medication, which week would you most likely see the most effects? And I think the answers were like 2, 4, 8, something like that. And you had to pick one of the smaller numbers, but not 2. Right, so either way, just remember PTU for the first month, and then methimazole the latter, not the first month, the first trimester, and then methimazole for the latter 2. All right, so that's your thiionamides right there. Quick little revision. 152. A 67-year-old woman comes to the physician because of a 1-month history of low back pain. She has hypertension, well controlled with a thiazide diuretic. Her pulse is 140 per minute. Blood pressure is 140 over 85. Physical exam shows tenderness to palpation over the L2 to 3 vertebrae. Lab studies show, hemoglobin looks okay, hematocrit, leukocyte count, segmented neutrophils, lymphocytes, okay. Platelet count looks okay. Serum electrophoresis shows a monoclonal spike of IgG kappa. A chest x-ray shows cardiomegaly with bilateral, pleural, and pericardial effusions. An x-ray of the spine shows a lytic lesion. And electrocardiography shows an echo-dense thickened left ventricle and poor diastolic compliance. A photomicrograph of a specimen obtained on myocardial biopsy is shown, and this is what you're looking at. Which of the following is the most likely cause of the cardiac findings in this patient? Right? And then you look at all your answer choices: acute infarction, myocarditis, amyloid, cardiomyopathy, plasma cell. For one thing, she is very old. She's over 65. And then if you think about, her symptoms, they didn't really talk about calcium directly, but they did mention the lytic bone lesion, right? They mentioned the lytic bone lesion. They mentioned back pain. I remember CRAB, right? CRAB. Those are all the symptoms of multiple myeloma. The calcium derangements, the renal issues, the anemia, and back pain or lytic bone lesions. So we do kind of see all of that in her. I mean, her hemoglobin isn't exactly anemic yet, but it is on the lower end, sort of. Also, keep in mind, you never really get myocardial biopsies, right? That's like, there's really only 3 case scenarios where you can never get it. One case scenario, which is probably the most common, is for rheumatic fever. You can get a myocardial biopsy, and they'll show you an Aschoff body, right? So that's one thing. You can get a myocardial biopsy because they're trying to show you lipofuscin in an extremely old person. You'll see some kind of pigmented thing, brown, orange. This is another scenario, amyloid infiltration. Okay, so this one is amyloid. You have to remember all the things of multiple myeloma, and amyloid is one of them. So let me see, this is page 463. So remember that the page numbers I have are from my PDF. The real page number is on the book over here, so 423. So in the question, they mentioned something that was pretty significant. They mentioned the serum electrophoresis with a monoclonal spike of IgG kappa. If you've done pathoma, then you know monoclonal things are pretty bad, right? Polyclonal is okay. When you have a monoclonal anything, monoclonal stuff is almost 100% guaranteed it's some kind of cancer. Monoclonal means that only one guy is making everything. So something is repeatedly multiplying, and it's just one guy that started it. Polyclonal is like, you have 5 different kinds of people inside you. They're all going to multiply. You're still going to have 5 different kinds of offspring. And it's just a very, very basic way of repeating that concept. So a monoclonal spike they're talking about is the M spike, basically. Right? This is the gamma, right? IgG. And this is the crab thing I was talking about. So hypercalcemia, renal anemia, lytic bone lesions, and back pain. Okay. So her case scenario in this patient is just about amyloid, which really isn't something that's here, right? They don't show you an amyloid biopsy, so that's a good picture to pick per se to test someone on. But you should know that what are all the things you see? You're going to see primary amyloidosis. You're going to see the Ig light chains in urine, also called Benz-Jones proteins. So be very careful. Sometimes they ask questions about multiple myeloma where they're going to be like, we did a urinalysis, what are you going to find? And then the first answer choice A, is going to be the IgG gamma, and you fall for it. You're like, yeah, there's IgG gamma is the M spike, but the M spike thing is the electrophoresis. In urine, you're going to find Ig light chains, also called Benz-Jones proteins. But the urine dipstick is going to be negative, okay? Because urine dipstick really only detects albumin. And that's really all for this stuff. So it was a pretty easy question, not that bad at all. 153, an 18-year-old woman receives general anesthesia for extraction of her wisdom tooth. After 5 minutes, she has generalized hypertonicity of skeletal muscles and increased body temperature. The most appropriate treatment is a drug that decreases, which is the following. So again, this is also a very easy, straightforward question. Anesthesia and then hypertonicity and increased temperature. That's pretty much directly talking about malignant hyperthermia, right? And you just need to give her dantrolene. Dantrolene prevents calcium release from the sarcoplasmic reticulum. Even if you didn't really know any of this, right? Logically, they're telling you she has hypertonicity of her skeletal muscles. So whatever you're going to give her, it has to stop that hypertonicity. It has to stop the flexing. And the only way to really stop the flexing is to stop the sarcoplasmic calcium release. Okay? So even if you didn't know malignant hyperthermia, you should be able to deduce that answer choice. And this is something we recently discussed, right? Because we just finished Neuropharm. So right here you can see your neuromuscular blocking drugs, right? This is the questions about succinylcholine and the curium and all of that. And the spasmolytics, right? So these are pretty high-yield medications. Dantrolene for anyone who needs help with their malignant hyperthermia. Baclofen is the GABA agonist for patients who have muscle spasticity and multiple sclerosis. Okay, multiple sclerosis is usually where you see this question, where you see this as the right answer. Cyclobenzaprine, we also spoke about, was just a medication you can give for anyone who has any kind of muscle pain. And I mentioned how I had to take cyclobenzaprine for quite a while because after I had a really bad car accident, and after that I had really bad muscle spasms in different parts of my body, and this was perfect. And it would knock me out too. It would put me to sleep. So it would have the sedation too. Okay. So there's a bunch of these medications. You really want to make sure you know them. This was a pretty straightforward question though. 154, 57-year-old man with alcoholism dies of Klebsiella pneumonia. Several abscess cavities filled with a purulent exudate are found at autopsy. Which of the following patterns of necrosis would be found in lung tissue within these cavities? So this is again another thing taught really well by pathoma, taught pretty well by first aid too. So this, you look at all your answer choices, and it's really going to come down to just between liquefactive versus caseous necrosis, right? If anything, you're going to be confused between those because there's definitely not going to be fat necrosis that's related to saponification and stuff like that from pancreatitis. It's not going to be fibrinoid necrosis because that's always about blood vessels. Definitely not going to be gangrene. All right, so liquefactive versus caseous, and this one is liquefaction. All right, this patient had a bacterial abscess, which are related to liquefactive necrosis. That's going to have many neutrophils digesting the tissue. Usually, you will have caseous necrosis in the lung due to TB, nocardia, or histoplasma, and C. granulomas as well due to macrophages. All right, so this could, a lot of people did pick caseous because they're used to seeing that. Anytime there's a question about pneumonia and the lung. However, in the question, they described abscess. Okay, so when you see abscess, you pick liquefactive. If we look at this real quick, 215. So up here I wrote, generally, coagulative necrosis can occur in any organ except the brain. It is simply due to ischemia leading to proteolysis and eosinophilia. Liquefactive necrosis occurs in the brain because the macrophage-like astrocyte activity. Liquefactive necrosis occurs anywhere you can digest everything to liquid. So this can occur in pancreatitis, where the pancreas digests itself. Although saponification and fat necrosis occurs too due to the lipids around it. Right, so there's that concept, and you really want to make sure you understand that. Do not get too confused by it. It's not that bad. Right, so coagulative, this is coagulation, this is proteolysis, denaturing, enzymes, okay? Liquefaction is neutrophils of any kind digesting the tissue. So you see bacterial abscess, and then the brain. Even in infarct, you see infarct anywhere else would cause coagulative necrosis, but in the brain, even the infarct causes liquefactive necrosis because brain has astrocytes that immediately start doing the digestion and cleaning up. Okay, caseous, fat, fibrinoid, and gangrenous are very straightforward. They're completely unrelated to stuff. Caseous necrosis looks very cheesy, and it's because macrophages are walling it off. And it's very, you see how it looks? It looks like you filled it up with cream cheese. So that's pretty easy stuff. Just really make sure you spend good time mastering the differences between caseous and liquefactive necrosis. These two are the ones that can often look a little confusing. We see coagulative necrosis all the time, all kinds of infarcts, MI, any kind of infarct except the brain. Right? And anywhere you have a bacterial abscess, no matter where it is, it's going to be liquefactive necrosis. So this one was just E, liquefactive necrosis. Right? They didn't even put coagulative as an answer choice. They should have. It would be very confusing even more, and it would drive the question to be more difficult. Um, 156. A 50-year-old man is admitted to the hospital after being diagnosed with a pulmonary embolus. Treatment is started with IV heparin. 24 hours later, warfarin is added. On day 2, his partial thromboplastin time is 52 seconds, and the prothrombin time is 12 seconds. Excuse me. Okay. Alright. Yeah, sorry, where was I? 50-year-old man admitted to... No, I skipped the question. We did this one just now. 155. 21-year-old woman comes to the physician because of a 2-day history of urinary frequency and pain with urination. Temperature is 102.2, pulse is 125, blood pressure is low. Physical exam shows right flank and suprapubic tenderness. Alright, so she's very young. Urine culture grows gram-negative bacteria. Which of the following virulence factors of the causal organism increases its adherence to the bladder epithelium? So this is generally just asking a question of which one of these can possibly even allow adherence of the causal organism to the bladder epithelium. Now, we know that the number one cause of a UTI is E. coli, right? And then the second highest cause of UTI in someone sexually active is your Staph saprophyticus. But this patient most likely has E. coli. Her case scenario looks pretty bad. And if you did sketchy micro, then you remember the Fimbriae very, very easily. If you didn't do sketchy micro, you should still pick Fimbriae. It's not going to be endotoxin that's going to allow adherence. Hemolysin and K antigen is also not going to allow adherence. So the only other answer choice that's left is kind of to consider flagella. But flagella is not the correct answer for this bacteria at all. So if we look at E. coli real quick, you have to remember all the different virulence factors of E. coli, right? So it's a gram-negative indole positive rod, and it has Fimbriae that cause the cystitis and pyelonephritis. This is another answer choice that could be there, P. pili, okay? K capsule causes the, you could see, this is the sketchy micro image. Let me just make it big. So this is the capsule here, right? Anything that's got a capsule, they usually depicted with some kind of covering in sketchy micro. And you can see this kid is reaching out for it, right? So this kid with the helmet on, he has meningitis. Alright, so K capsule causes neonatal meningitis or pneumonia. And then LPS endotoxin, which is pretty much there because this is gram-negative, it just causes the septic shock. Right, so very straightforward. So you can see the girl here, right? She's got the number 1, and the ureter is coming out of this. So it looks like urine in here. This looks like the bladder, basically, the urethra, blah, blah, blah. So number 1 causes UTI. And her head, the red bands that she's wearing are supposed to remind you of Fimbriae. Okay, so that's basically it for there. Other than that, the rest of this image here is about hemolytic uremic syndrome here. Right, this scenario where a young kid might have had bloody diarrhea, so he's on a red stool, bloody diarrhea after having some kind of undercooked meat maybe, and now he has hemolytic uremic syndrome. Okay, so that's one case scenario. This is heavily directly related to the 157 E. coli. Outside, you're looking at LA and SG for the traveler's diarrhea. Okay, traveler's diarrhea. These toxins are very similar to cholera, and the SG is for stable, is cyclic GMP, right? So labile in the air, stable in the ground is another memorization method that people use. So critical little tiny facts that you really want to make sure you grab. And hemolytic uremic syndrome is something you need to know really well. It's spoken with TTP. They're both discussed together in HEMOC. So yeah, if you don't know what the main concepts of HUS and TTP are, definitely go back and review that page. This one, 50-year-old man is admitted to the hospital after being diagnosed with a pulmonary embolus. Treatment is started with IV heparin. 24 hours later, warfarin is added. On day 2, his partial thromboplastin time is 52 seconds, and prothrombin time is 12 seconds. Which of the following is the best explanation for the normal prothrombin time and INR measurements in this patient? Right, so this patient had a pulmonary embolus. They gave the patient heparin. Heparin, HTTP, so PTT. Heparin is supposed to prolong the PTT, right? And then after doing the heparin bridge, they started the patient on warfarin, which prolongs PT. But it's only been day 2 so far. Remember that whenever you get questions about heparin and warfarin, heparin is very easy, right? Heparin is super easy to understand. Heparin just potentiates antithrombin, which is factor 3, potentiates antithrombin to go ahead and turn off factors 2 and 10, okay? And warfarin works against 2, 7, 9, 10, and C and S. Heparin can have issues like HIT, which is not related to this question at all. Warfarin can have issues like the warfarin-induced skin necrosis due to hypercoagulation, which is sort of related to this question, but this question isn't about that. But the reason it's related is because that's why they did the heparin bridge, so you can kind of avoid the potential aspect of having warfarin-induced skin necrosis. And then you remember why they're doing it, right? So the reason you're supposed to do this is because when you give heparin first, you are able to get rid of factor 2, then give warfarin to get rid of protein C and S and everything else. Otherwise, if you don't do that, if you just directly start somebody on warfarin, then you have to remember factor 2 has a very, very, very long half-life. The way you remember that is, you think of the statement, step 1 is too long, the 2 being the number 2, and you remember that factor 2 has the longest half-life. Factor 7 has the shortest half-life, and you can remember that because of the 7 dwarfs, okay? So that's one story that helps you remember it. But protein C overall has the tiniest half-life. It's immediately gone right after being made, pretty much. So protein C and S are supposed to stop the coagulation cascade, right? If you start somebody on warfarin, you kill protein C first. Now you cannot stop the cascade, but factor 2 is still there, so you end up having hypercoagulation. So in this patient, they're doing the right things, right? They gave heparin first, then they started warfarin. However, even after starting warfarin on day 2, his PT is still pretty much normal. And you look at your answer choices, so heparin-warfarin interaction, no. Hereditary resistance to heparin. If there was a resistance to heparin, then, right in the beginning when they gave heparin, there would have been no change to PTT. Hereditary resistance to warfarin, that is a bait of an answer choice, okay? That they're just baiting you. There really isn't such a thing to really have warfarin resistance, and if you do have warfarin resistance, then then this will be the correct answer choice. So it is a good bait, but you still gotta look at your other answer choices. So answer choice D, long half-life of factor 2, E, too low a dose of heparin, too low a dose of warfarin, undetected liver disease. Okay, so now the last 3 you can easily cancel out, because if it was a low dose of heparin, again, PTT would not be affected. Could it be a low dose of warfarin? Again, another bait of an answer choice. Okay, so resistance to warfarin and too low a dose of warfarin were definitely other answer choices I'm sure many people picked. Undetected liver disease, if you have liver disease, you're not going to make 2, 7, 9, and 10, so his PT would already be pretty high. Alright, so it's not that either. So we're really down to just picking between C, D, or F. And the correct answer here was just D. That's the most likely and most plausible answer choice to pick. All right, heparin stops production of factors 2 and 10, and warfarin stops 2, 7, 9, 10, C, and S. This patient has an increased TTP because heparin did that, right? Heparin, which is related to the intrinsic pathway. Upon starting warfarin, 24 hours the heparin bridge, the patient's PT, which is for the extrinsic pathway, and warfarin did not increase. And INR is still 1, but you want it between 2 and 3 once you start warfarin. Any derangements after starting warfarin are due to the short half-life of C and long half-life of 2, leading to warfarin-induced skin necrosis. Okay, so you always pick either one of those answer choices. Either the correct answer choice will be because protein C has a very, very, very short half-life, or because protein factor 2 has a very long half-life. So basically, not enough time has passed. That's it. All right. So remember, warfarin is for chronic treatment. This is only day 2. By like the fourth or fifth day, by the end of the first week, his PT should go up, and his INR should become more in the range of 2 to 3, which is how you pretty much put somebody on long-term warfarin use. Okay, so that's all this question was about. Very interesting question, though. Very important topic to master. Heme pharmacology is a big chapter, but the heme pharmacology is pretty small. Is the oncology aspect that's a longer one. So make sure you really understand heparin and warfarin and the whole coagulative pathway very, very well. And then I continued, actually I explained a little more because I know a lot of people are confused about this question. So I wrote, basically PTT is elevated, so heparin is definitely working by depleting factor 10. PT is not elevated, so warfarin is not working. The only answer choice with any coagulation factor relevant to warfarin is choice D. Hereditary resistance to heparin is seen in antithrombin deficiency, where people are missing the antithrombin, which is just factor 3, where the administration of heparin does not increase PTT. Okay, but that's not what happened here. Warfarin resistance is autosomal dominant and extremely rare, and I had to look it up online, but it's not something that's related to this question at all. And F, too low a dose of warfarin, is an unreasonable answer, because it's just not something, there was no reason for us to think of dose because they're not really mentioning any dosages. And that's really all there was to this question. So it was an interesting question. I know a lot of people got it wrong, but just make sure you remember the half-life thing, and that'll really keep everything straightforward. 157, 34-year-old man who is a potter has burned his hands while firing pots on several occasions over the past 3 months. He has no pain during or after a burn, right? So he's not able to feel the burn. Examination shows mild atrophy of the arms and hands, absence of deep tender reflexes in the upper extremities, and decreased pain and temperature sensation, which is directly related to spinothalamic tract. Right, so you know this is going to be Syringomyelia. This is the same kind of scenario you always get for Syringomyelia. This guy is a potter. Other questions are going to be like a woman who's always burning her hand in the kitchen when she's cooking. It could be a man who's out, working in like fields, and he keeps hurting his hands with like hot things that he's working with, and he just can't feel the temperature, right? So those are the basic concepts of that, and this was very straightforward because they even gave a very easy answer choice. The answer is straight up just Syringomyelia. They didn't put it in any kind of confusing way. 158, a 2-year-old girl is brought to the emergency department by ambulance 30 minutes after having a febrile seizure at daycare, right? So febrile seizure, very important. Physical exam shows nuchal rigidity, bacterial meningitis is suspected. A lumbar puncture and immediate antibiotic therapy are planned, but the parents are not available to provide consent for the procedure and treatment. Which of the following is the most appropriate next step in management? It's a 2-year-old girl. You just do it. You just go ahead and do it. That's it. Really don't need to think too much about it. Pick whatever answer choice says to just go ahead and do it, and that's answer choice D. Initiate the procedure and treatment without consent. They wrote the answer choice like that to really kind of make you think like it doesn't, look right. When it says without consent, many students will often be like, oh shit, no, without consent, that doesn't look right. But the other answer choices really don't look right at all. So you just pick D and you move on. That is how you work with these things. 159, a 3-year-old boy is brought to the emergency department by his parents because of progressive fever and skin lesions during the past 24 hours. He appears ill. His temperature is 39.4, pulse is 120 per minute, respiration is at 20 per minute, and blood pressure is 110/60. Physical exam shows large flaccid bullous lesions that are prominent over the trunk and abdomen. Which of the following additional findings is most likely in this patient? Okay, so they tell you the physical exam, which is always very important, so you always want to reread that, right? Large flaccid bullous lesions over the trunk and abdomen. He has a high fever, 3-year-old. What are you going to pick now? So you look at your answer choices. Elevated eosinophil count, no. Gram-negative rods in the bullous fluid. If you can think of a gram-negative rod that can cause something like this, then definitely go ahead and pick it. Multinucleated giant cells on a scraping of an unroofed lesion. Okay, so multinucleated giant cells, they're basically talking about herpes, which would cause vesicular lesions, right? They didn't describe vesicular lesions in the physical exam. D, positive Nair's culture for toxin-producing Staph aureus. That answer choice you can't really go wrong with because everyone would probably have positive Nair's culture for toxin-producing Staph aureus. right? Like even you and I, because Staph aureus is actually part of there. It just doesn't cause infection in us because we're not, we're not suppressed in any way. So that was the answer here. This guy just has Staph aureus, okay, Staph aureus infection. You could pick D because it's true for almost all of us. In addition, the boy's symptoms are of toxic shock syndrome. That's what they're describing here. Right, so that's what I put a little picture of right here too. This is basically what his lesions kind of look like. And 136 in microbiology, we discuss Staph aureus, right? So Staph aureus, the first picture in Sketchy Micro that you ever learn about. Staphylococcal toxic shock syndrome, fever, vomiting, rash, desquamation, shock, end organ failure. They didn't really give you any of this for this patient. They kind of just gave you a physical exam, and it's a young-ass kid who has these bullous lesions. And the answer choices weren't really that confusing either. They didn't try to make you think it might be like bullous pemphigoid or something autoimmune, right? It was literally just him having toxin-mediated toxic shock syndrome. Okay, so there are no gram-negative rods that you could pick as an answer choice either. Eosinophil would be more so related to like protozoal stuff, so you don't really go with that, right? Protozoal stuff, and parasites actually. Okay, so you're not gonna pick elevated eosinophil count. 160, a 45-year-old woman comes to a physician because she recently was diagnosed with cholecystitis. So cholecystitis is gallbladder stone. She asks the physician why her abdominal pain is intermittent and not constant. Okay, so you already know the answer when you read that, right? Because she's going to have gallbladder pain every time her gallbladder contracts, which is going to be related to every time she eats something that releases CCK. The physician explains that pain is produced when the gallbladder contracts against the gallstone that is obstructing the cystic duct, right? Secretion of hormones from which of the following cells is the most likely cause of this contraction? And you need to remember that it's the eye cells. However, they were being clever with you in this, and they didn't put it as an answer choice, okay? So you don't see eye cell in your answer choices, and you're like, oh shit, all right. So now you start focusing a little more, and you look at your other answer choices correctly. So A, central acinar cells of the exocrine pancreas. You know the pancreas has nothing to do with gallbladder contraction, generally speaking, so you don't work with that at all. Chief cells of the gastric mucosa don't release this either. Enteroendocrine cells of the small intestine looks like the most plausible. Gastric parietal cells, you know what they do. VIP producing cells of jejunal mucosa obviously don't make the CCK either, so it was just to pick C. Alright, CCK is secreted by duodenal and jejunal eye cells, which are also known as enteroendocrine cells. Alright, I always talk about how GIT is the easiest chapter of all of first aid, so you definitely want to make sure that the first time you do your deep revision of GI, that you get it all down perfectly. Alright, you want to make sure you have this either printed out or handwritten out, whatever it is you do to study, and get this stuff down very well. So CCK right here, eye cells, it actually goes and increases pancreatic secretion, increases gallbladder contraction, slows down gastric emptying so you could digest shit, and it increases sphincter of Oddi relaxation. Right? Pancreatic and gall secretions go to the major papilla, which empties into the duodenum through the ampulla levator via opening of the sphincter of Oddi. So that has to be relaxed. Okay, so CCK is important for normal pancreatic function as well. Okay. And that's definitely something you can get questions on. Acts on neural muscarinic pathways to cause pancreatic secretion. Alright, so very, very nice thing. They don't write enteroendocrine cell here either, but that's just something you should be able to break down, right? Entero is anything that has to do with your intestines, your GIT, and endocrine is just endocrine, right? Releasing of hormones. So this is releasing a GIT hormone, and that fits, okay? But they don't need to do shit like that, right? They should have just put eye cell as an answer choice and just get it on with. 161. This was a good question. This was actually pretty hard for anyone that might not remember some of these answer choices. So a 35-year-old man comes to the physician because of several episodes of squeezing chest pain during the past 2 months. Physical exam shows no abnormalities. An angiogram is done that shows normal coronary arteries. During the angiogram, the patient receives an IV infusion of norepinephrine, and his total coronary blood flow is monitored continuously for 5 minutes. Right, so they gave him norepinephrine, and then time in minutes is at the bottom, so this is where they gave him norepinephrine. Now, the graph as shown depicts the results following any infusion. Which of the following substances is the most likely cause of the increased total coronary blood flow observed 1 to 2 minutes after the NE infusion? Okay, so what happens? So coronary blood flow, after giving NE, coronary blood flow went down, right? Then around 1 minute, it looks like something else started playing a role, and coronary blood flow increased. So you have to pick an answer choice that would cause vasodilation of your coronary blood vessels. And you look at all your answer choices, you can knock out a couple things that definitely don't have anything to do with coronary blood vessels, and then it's just general memorization of cardiac pharm. Adenosine is very important. Adenosine has two mechanisms. In blood vessels, it uses alpha-2 and GS to make more cyclic AMP and cause vasodilation. And sorry, not alpha-2, it's actually called A2. Not the same thing as like the sympathetic alpha-2 and alpha-1. This is actually called A2 adenosine receptor. Alright, so in blood vessels, we have A2 receptors that use GS to make more cyclic AMP and cause vasodilation. In the SA and AV nodes, it uses something called the A1 node, A1 receptor, and GI to decrease cyclic AMP and slow down the heart rate. So since it has two different mechanisms of action in two different places, it makes for a great medication to ask questions about. Okay, so you want to make sure you remember that. I think I talked about it in good depth when I did cardiac pharmacology. There's also a picture right here, right? This one. Okay, so you can see in vascular smooth muscle, it uses A2 and GS to increase cyclic AMP and cause relaxation of blood vessels. Okay, so that's the coronary blood vessel dilation right there. But in SA and AV nodes, it decreases chronotropy and dromotropy by using A1 and GI. Right, decrease cyclic AMP. Two different mechanisms of this medication. Generally speaking, it increases potassium coming out of cells, causing hyperpolarization. Right, potassium coming out is supposed to be related to repolarization, but this is going to end up with hyperpolarization and decreased calcium, decreasing the AV node conduction. Drug of choice for terminating SVTs. So this medication often pops up in questions about supraventricular tachycardia, and it's very short acting. All right, so it's not going to cause any long-term effects. And people who have theophylline or just had caffeine, just drank coffee before taking adenosine, are not going to see the effects of adenosine because adenosine and caffeine kind of both compete. All right. Adverse effects are often tested for adenosine also. So there's this cool feeling of sense of impending doom. So after taking adenosine, you could feel like you're about to die. Right. So it's a very short-lived side effect that occurs. Very interesting thing. Not really high yield, but it can pop up. Generally speaking, I have seen questions about adenosine causing flushing and chest pain. So you want to make sure you remember that. Right? Bronchospasm, flushing, chest pain. So tiny medication, very short topic, but definitely is a topic that pops up. You want to make sure you know it. Right here I wrote dipyridamole and regadenoson are A2A adenosine receptor agonists that cause coronary vasodilation for stress tests. Right? And they can cause myocardial ischemia in the case of coronary steal syndrome. Okay, so these two medications don't really get talked about much. They are discussed in cardiac physio, and that's about it, really. This was an AMBOSS question related to adenosine. Same topic, okay? And then they ask you which of the following adverse effects is most likely to occur, and the correct answer here was chest pain, right? Because adenosine, remember, can cause chest pain because of coronary steal syndrome and many other things, many other issues. So you want to make sure you remember the side effects. Pretty important medication, just not extremely high yield. 162, a 6-year-old boy is brought to the physician by his mother because of a 5-day history of intermittent vomiting and a 3-month history of progressive clumsiness. His mother says that he can no longer ride his bicycle and has difficulty getting in and out of the car. Fundoscopic exam shows bilateral papilledema. Neurologic exam shows impaired upward gaze and pupil response to the right. Sensation is intact. He walks with a shuffling gait. CT scan of the head shows enlarged lateral and third ventricles and a 2-centimeter mass. Which of the following is the most likely location of the mass? So they gave you a lot in this question. Like, they didn't need to give you the CT scan of the head at all. It was enough to tell you that fundoscopic exam is showing bilateral papilledema, which means there's increased intracranial pressure, which is probably due to a mass, because this is a 6-year-old boy. He wouldn't have any other reason to have elevated intracranial pressure. And then describing the neurologic exam of impaired upward gaze, right? So that's Perinaud syndrome. Perinaud syndrome starts with the P. Perinaud syndrome should always remind you of a pinealoma. And you look at your answer choices, and the only answer choice that really did explain everything in this question was to have a mass in the pineal gland, right? Because if a mass in the pineal gland would lead to the CT scan findings in this patient of an enlarged lateral and third ventricles, because you end up compressing at the aqueduct of Sylvius. Okay, so that's what I didn't even write that here, but you just definitely want to be able to memorize that. So let's take a look at 572. Not even memorize, deduce that, right? You should be able to think about that. So 572 pinealoma, right? I wrote over here. Let's look at everything pinealoma related. So pinealoma. Okay, so tumor of pineal gland, Perinaud syndrome, compression of the tectum leads to vertical gaze palsy, so you can't really look up or down that well. Okay, obstructive hydrocephalus because of compression of the cerebral aqueduct, and precocious puberty, which is another very high yield topic about pinealomas, because in males it'll cause excessive ACG production, which is really only seen in this, and then in where did I write it? Was it this question actually? Oh yeah, this is the question. In seminoma, right? Now, this is also pinealoma. Oh, it's already in the book itself. Yeah, similar to germ cell tumors, testicular seminoma, right? So that's another case scenario where you would have excess HCG production in an adult, right? Not an adult, in a male. Okay, so people who didn't really study that topic very well will always fall for that mistake, because questions are going to have like, what hormone would you find elevated? And then you immediately write off ACG like it can't be ACG. We all associate ACG so much with just pregnancy, right? And females. But no, in males, you can have high ACG if they have a pinealoma or a seminoma. Okay, so make sure you remember that. And then the flow of CSF. Flow of CSF is very critical. So if you have enlarged ventricles like the one in our question, you have to know where the obstruction is happening. And in pinealoma, it's an obstruction of the cerebral aqueduct because it's in that area where the pineal gland is supposed to sit. And you can see here, right, images craniopharyngioma. So with pinealoma, you wouldn't get an image like this, but for pinealoma, you also get something that often looks very much just like a pituitary adenoma, very similar because of the same kind of location of the two glands. So don't fall for pituitary adenoma. Like, pituitary adenoma is not supposed to cause Perinaud syndrome. So that's always going to be something that'll help you understand pinealoma. 163, a 35-year-old man with Chagas disease comes to the emergency department because of a 2-hour history of moderate chest pain. He had a 4.4-pound weight loss during the past 2 months. His pulse is 100 per minute, respirations at 25 per minute, and blood pressure is 135 over 90. An ECG shows no abnormalities. A barium swallow shows a dilated esophagus with beak-like narrowing at the level of the lower esophageal sphincter. A biopsy of that lower esophageal sphincter is most likely to show which of the following. So that's directly, this barium swallow that they described directly is describing achalasia, right? And achalasia is due to a loss of those nerves. So you just pick E, loss of neurons in the myenteric plexus. That's it, right? So let's take a look at these things. So 163 discusses trypanosoma cruzi, which they really love talking about in NBME. I've seen so many questions on trypanosoma cruzi, so many questions on leishmania. Right? I haven't seen trichomonas yet, and then I saw a lot of questions on before that. Let's see. So definitely these two, leishmania and trypanosoma. Yeah, these two guys, Plasmodium and Babesia, they love. Didn't really see any questions on these guys. I think that's about it. Yeah, they don't even ask many questions on these guys because these are actually pretty high yield. Right, so NBME and Step 1, generally speaking, have been leaning towards things that they think students wouldn't really be studying or focusing on too much. So make sure you're ready with that. So trypanosoma cruzi, right? Chagas disease. This thing is called the Romagna sign. Make sure you don't get confused and pick anything else if they give you a picture like this. Okay. I think this would make a great image for someone who might be like, another answer choice could be like physical abuse, right? It looks like someone hit her or something. Don't fall for that. This is the Riemannian sinus, a unilateral periorbital swelling characteristic of the acute stage of Chagas disease, right? Which can cause dilated cardiomyopathy, is one of the C's of ABCCCD for Chagas disease. It can cause megacolon and megaesophagus, all of which is very apparent in this image right here. This is Chagas trigonosomal cruci image, right? So you can see megacolon here, you can see the megaesophagus here in the snake, okay? You can see the bag over here is dilated cardiomyopathy. So you got to make sure you catch all of that. Right now, this patient has achalasia, but not exactly real achalasia, more so like pseudo-achalasia. So page 407 is where we talk about that. So right here, achalasia, absence of relaxation. That's what achalasia means, achalasia. Secondary achalasia is pseudoachalasia, may arise from Chagas disease or extraesophageal malignancies like a mass effect or paraneoplastic syndrome. Right, and these are recordings you have to understand really well. I've talked about these when we did the GI PAP videos. I talked about it in good depth. These are also very important, related to like the differences between HSV versus CMV esophagitis and what they're supposed to look like, reflux esophagitis and then candida esophagitis. Right, very important to be able to differentiate all that. But yeah, right. So this is the bird's beak thing they were talking about in our question. And that was a giveaway for the fact that this patient does not have peristalsis, absent peristalsis with a high lower esophageal sphincter resting pressure, which means it's constricted, a high resting pressure. Okay, and that's kind of what you see right here. You see in achalasia, the resting pressure is super high compared to normal. Right, the line is much higher. All right, and this is due to loss of your myenteric Arbach plexus. Right, so no NO or VIP is being released. 164, another acid-base physiology question, very high-yield topic, especially for NBME. They love asking questions about acid-base physiology. And acid-base physiology is such a big topic, I'm actually thinking of making a separate video about it, because you need to be able to look at a question and really figure out what's happening with someone's pH, PCO2, and bicarbonate just by deducing the logic, right? It's not a memorization thing. Some things can be memorization, and this question was actually a memorization thing. An 18-year-old woman is brought to the emergency department 12 hours after she ingested approximately 100 aspirin tablets in a suicide attempt. So there is no logical deduction here because you might not remember what aspirin actually causes and you have to remember that. Physical exam shows tachypnea. Which of the following sets of lab findings would most likely be found in this patient? All right. So aspirin causes respiratory alkalosis in the first 3 hours and then later leads to high anion gap metabolic acidosis. Right? So if it leads to metabolic acidosis, everything will be low, and you pick the answer choice where everything is low. Right? So the pH should be less than 7.35, the bicarbonate should be less than 24, less than 20, and PCO2 should be less than 40 due to the hyperventilation for compensation. Remember that metabolic derangements are immediately compensated, very delayed. Metabolic things are immediately compensated because you can easily control your breathing, right? You can breathe very fast or breathe very slow whenever you wish. But metabolic compensation takes a long time for you to figure out, how much bicarbonate you're going to be absorbing or dumping. So initially, hyperventilation and respiratory alkalosis occur because aspirin stimulates the respiratory centers in the brainstem. Later, metabolic acidosis occurs because aspirin uncouples oxidative phosphorylation, impairing Krebs cycle and causing lactic acidosis. Right? So theoretically speaking, you could logically deduce what it would do, but a lot of people tend to forget these little things. Patients would also have tinnitus due to cranial nerve 8, which is something that is an errata in First Aid 2019. They wrote cranial nerve 7 by mistake. It's supposed to be cranial nerve 8. Acute respiratory distress syndrome, renal insufficiency, and increased bleeding time. Okay, so those are all the things you see. Remember that patients who've been taking aspirin, you have to wait for at least 2 weeks for their new platelets to be made. Acetaminophen overdose is a differential, which can be distinguished by hepatic failure and lack of tinnitus. And in acetaminophen overdose, you just give N-acetylcysteine. So let's take a look at, here the answer choice was just C, where everything is low. Let's take a quick look at acid-base physiology. We revisited that page so many times because there's so many questions on acid-base physiology. Where's renal acid-base physiology? Okay. So you see, if you forget about the color coding stuff here, right? The red arrows and black arrows. Just think of everything in the same color. In metabolic acidosis, everything is low. You see, pH is low, CO2 low, bicarbonate is low, and you have immediate hyperventilation because you have a metabolic derangement. So to fix it, you have to do a respiratory thing, and we can control respiratory things very quickly, right? So we start breathing very, very quickly to try to get rid of acid because we lost bicarbonate, right? Metabolic acidosis, you have low bicarbonate, so you're becoming, very acidotic, so you need to get rid of acid by breathing out a lot of CO2, right? So that's it. And then you can see in metabolic alkalosis, everything is high. All the arrows are pointing up, okay? And you start breathing very slowly so you can retain CO2, which is acidic, right? This all changes in respiratory, but you have to remember that if you have a respiratory problem, if your acidosis or alkalosis is actually due to respiratory issues, the renal compensation is going to take a while because it takes time for your kidney. You can't control it, right? You can't physically go into your kidney and do something like flick a switch and stop dumping bicarb, right? So that takes time for your kidney to adjust itself and figure out what it wants to do with bicarbonate. So when you have respiratory acidosis, you have to understand that this patient has acidosis simply because they're not breathing fast enough, right? So they're definitely breathing very slowly and they're retaining a lot of CO2. This could be due to someone who has opioid overdose or something. And their pH is going to be low, their PCO2 is going to be high. And the only way to fix this is to also increase bicarbonate, right? You have to mimic bicarb and PCO2 to keep things equal, right? Keep things equal, keep things balanced. So if your PCO2 is high, then your bicarbonate also needs to be high so you can cancel each other out, right? That's kind of what we were seeing in metabolic derangements. Everything's pointing the same direction. And respiratory alkalosis occurs because you're breathing too quickly for whatever reason. Maybe you have a panic attack, right? Panic attacks can do that, and there you go. So now you're losing all your CO2. Your pH is very high, and it's going to take some time, but you're going to have to mimic the PCO2 by retaining bicarbonate to cancel these things out. Right, so very easy memorization, very easy to reproduce this table. The harder part is actually being able to logically deduce what's happening in each one of these scenarios on this table, right? And that takes time, right? I've listed out all of them the best I could. Adenosine, con, right? Uremia, alcohol, iron, vomiting, loop and thiazide diuretics, salicylates, like in our patient with the aspirin. You really want to spend some time making sure you can actually explain each one of these scenarios and why they fall under whichever category they are in on this table. Right. So that's 164. 165, this is a chlamydia question, but a very nice question, actually. I liked it because it points out on something that Sketchy talked about a lot. So 10-day-old male newborn is brought to the physician by his mother because of a one-day history of red eyes with discharge. Right? So red eyes with discharge is basically conjunctivitis. Pregnancy and delivery were uncomplicated, but the mother did not have prenatal care until the 3rd trimester. The mother recalls no contacts with ill people since his birth. Physical exam shows bilateral conjunctival injection with a watery discharge, which is a very important description. Which of the following infectious agents is the most likely cause? And then they put both things here, right? They put chlamydia trachomatis and they put Neisseria gonorrhea. You can immediately knock out CMV, parainfluenza, and strep pneumo because this isn't about that. But, with the torches infections concept, a lot of people did fall for cytomegalovirus, and that was the wrong answer. Here the correct answer is A. With the watery discharge and the conjunctivitis, you always go with chlamydia. Neisseria gonorrhea causes a very thick discharge, okay? And the way you remember that is really just because of Sketchy Micro. And Sketchy Micro, chlamydia is occurring in an island in the middle of nowhere, and there's water everywhere. So it's a watery discharge. It also takes a long time. It doesn't occur immediately. Right? So they're saying this is a 10-day-old male newborn. So it's been 10 days since the boy was born. Now you see it. In gonorrhea, you have, within the first 2 to 3 days, right, rapid onset of very waxy, thick discharge. And the reason they say wax is because in the gonorrhea image, they use candle wax a lot. So let's take a look at both, right? 150 and 143. So 150 is the chlamydia image, right? So you can see chlamydia right here. This is under the eye. You're looking at it basically. Actually, wait, is it under the eye here? Yeah, follicular adult conjunctivitis, right? And this is the image for you. So you see how it's in the middle of nowhere on an island, right? And in this one, this mermaid is actually holding a baby and covering its eyes because that baby has conjunctivitis. Okay, very important to remember that. The other thing that's significant for chlamydia is the whole Rider syndrome stuff, right? So you can see these monkeys, right? Can't see, can't pee, can't climb a tree. Basically, that's the general thing. This guy can't see because he's holding a telescope wrong. This guy can't pee because he hit his penis on the pole over there, and this guy can't climb a tree. And so very important to remember that stuff. The Rider stuff is pretty important. It pops up quite often. And trachoma, the number one cause of blindness. And where is it? Where's trachoma? Chronic infection causes blindness due to follicular conjunctivitis. Yeah, number one cause of blindness in Africa. Okay. Lymphogranuloma venereum is the other guy. That is a painless ulcer. Remember also to, if you haven't studied it in a while, remember also to go over all your STD, STI type of ulcers and which ones are painful and which ones are painless. That's always very easy to differentiate between. And they tell you here, right, neonatal conjunctivitis 1 to 2 weeks after birth. Right, so that's what happened in our patient. Now, Syringomyelia 143, in that one you'll see that it actually occurs indoors somewhere, and there's candle wax, right? So you can see in this picture right here, there's another woman hiding her baby's eyes because she doesn't want the baby to see how this guy just died from the statue that fell on him. And you can see this wax that's dropping, right? That's the waxy discharge that the conjunctivitis would have, okay? So if you haven't done sketchy micro and you have a lot of time before your test, you should spend a week and get through all the sketchy micro. Totally worth it. 166. A 36-year-old woman who was recently diagnosed with HIV infection comes to the physician for a follow-up exam. 2 months ago, an antiretroviral therapy regimen consisting of efavirenz, emtricitabine, and tenofovir was initiated. Lab studies show CD4 plus T lymphocyte count at 352, which is very low. Undetectable HIV viral load. 2 months ago, her CD4 count was even lower, so she's improving, and her plasma viral HIV load was very high. Right, so she's getting better. Everything's going fine. Which of the following is the most appropriate next step in management? Don't do anything. Right? If it's working, why would you change anything? So you just pick G. Continue efavirenz, emtricitabine, and tenofovir with no changes. There's no reason to change. I really didn't understand this question. Like, how is this even a question, right? But I'm sure there's something that someone can think incorrectly and maybe pick a wrong answer, but there's nothing wrong with the patient. She doesn't need anything. She's getting better. Her HIV viral load is no longer detectable, and it was very detectable before, so the medications are working. Tenofovir is a nucleotide, right? So you have to remember that. Tenofovir is a nucleotide, and emtricitabine, as well as many others, are nucleoside, and they're all NRTIs, okay? Efavirenz is an NNRTI, and it ends in Z. It can cause vivid dreams and CNS symptoms, right? Efavirenz, you write like 3 Z's at the end. This patient should continue the heart therapy and possibly even add a protease or integrase drug if necessary or if affordable, but no reason to stop any of the drugs, right? So I don't know what the question writer was thinking. Like, why would you, in any mindset, pick to not give any of those medications anymore? It was working, right? So spend some time on another day to make sure you memorize all these medications. Now, you don't need to memorize all the medications. Dolutegravir, these are integrase inhibitors. Very easy to remember that, right? You don't need to remember it because you're going to see it. The navirs are all proteases, okay? Delavirdine, efavirenz, and nevirapine are 3 medications that have weird names that pretty much makes them look like these guys up here. Okay, so these ones you have to make sure you remember. More so, I would just memorize these 3 medications. Just memorize these 3 medications. Remember that they are NNRTIs, and the fact that efavirenz, right, can cause vivid dreams and CNS symptoms. Otherwise, they all cause rash and hepatotoxicity. Very common. That's it. Any other medication you see is an NRTI. So abacavir, adenosine, emtricitabine, whatever you might see. Sidovudine. Now, as far as memorizing side effects, that takes time. You have to revisit it. You make a you make a little card for yourself. Look at it throughout the day until you memorize it. Throw the card away. Right? But make things to actively memorize things. Now these are your entry inhibitors, right? Entry inhibitors, enfuvirtide and maraviroc. Enfuvirtide is the one that stops fusion, right? So fusion requires GP41, and maraviroc allows it to dock, which requires GP120 docking. That's it. Very easy to memorize these medications. It just takes time. So, give the time, invest the time, and you will memorize it. 167. Okay, these are also very easy to memorize, but a lot of people, hate pharmacology, and I don't blame you at all. But you have to invest time. That's really all it is, and come up with clever things if you can. For 167, an investigator is studying the innate immune response to fungi in an experimental animal model. Fungi expressing beta-glucans on their cell surfaces are found to trigger protective innate immune responses. Which of the following antifungal drugs is most likely to alter this response by decreasing the glucan expression of the fungal cell? So you look at all your answer choices, which one of these is actually going to inhibit glucan formation? And that's just B, caspofungin. Okay, look at all your answer choices: amphotericin B, flucytosine, terbinafine, and voriconazole. If you don't remember where all these medications fall, then you need to study that, right? That means that you need to just stop studying whatever you are studying and memorize this, right? Depending on what stage you're at. If you just start studying, then please keep going with what you're doing. But if you're pretty close to taking your test, go spend a day on memorizing this stuff. It's not that hard at all. This patient needs a medication that reduces glucan expression. Fungins are echinocandins. Okay, echinocandins. So caspofungin, and there's another one. They're all echinocandins that affect cell wall synthesis by inhibiting beta-glucan synthesis. So you see, it's called an echinocandin, glucan inhibitor, right? Fungin, fungus inhibitor. That's another way you can just, if you just look at the GIN at the end, gin, right? The glucan inhibitor. That's another way you can try to memorize that if you want. Amphotericin B is terrible, okay? Amphotericin B and nystatin, they're both polyenes that affect cell membrane integrity. Amphotericin has many bad side effects, but it's a very strong medication, so some life-threatening conditions really require it. Flucytosine is a nucleic acid synthesis inhibitor that works like 5-fluorouracil, right? Flu, you just remember that too. Terbinafine is actually sold as Lamisil. This is a medication used for nail fungus. It inhibits squalene epoxidase and messes up cell membrane ergosterol formation. All the azoles also work on the same thing, but at a later step by inhibiting 14-alpha demethylase and stops the cell membrane ergosterol formation, basically. Voriconazole is for aspergillus, while isovuconazole is for serious aspergillus and mucor. There's a bunch of medications that are more specifically talked about in the pharmacology section, so you just, again, make cards, write it down, keep looking at it throughout your entire day, throw it away once you memorize it, and then you're done. But the whole class of medications for antifungal therapy, not that bad at all. Antiviral therapy, anti-HIV therapy, very easy to memorize. The only medications you really need to memorize are these three. The others all are named well. And the antifungal therapy, look at this page. Right? There's really not much happening. Terbinafine is the only one that affects squalene epoxidase. All the azoles affect here at 14-alpha demethylase. Flucytosine is nucleic, like 5-fluorouracil. The polyenes, amphotericin and nystatin, they actually are there to affect cell membrane integrity. Okay, and then echinocandins are for the glucan, so glucan inhibitors, and you can see they all end in fungin. All right, not that bad at all. And the thing you invest more time in later are the understanding of their side effects. And amphotericin is really, really bad. This guy can cause IV phlebitis, which often shows up in questions that tries to confuse you into thinking it might be a patient with like platelet dysfunction or something. It can cause arrhythmias, right? You have to give hydration with it to decrease renal injury, and liposomal amphotericin decreases toxicity. Okay, so really not that bad at all. You can spend some time going through these and you'll get it down just fine. The only one that wasn't mentioned was griseofulvin. Right, griseofulvin is the oral treatment of superficial infections. It inhibits dermatophyte growth like tinea and ringworm and stuff like that. Interferes with microtubule function, disrupts mitosis. Okay, deposits in keratin-containing tissues. But it is teratogenic. It's also carcinogenic. It's also related to your P450, increases P450 and warfarin metabolism, which is why this medication ends up being pretty high yield. Otherwise, what it does and how it's used is really easy and straightforward. 168 was also a good question. 3-year-old boy brought to the physician for a follow-up exam 7 days after he was diagnosed with severe chronic diarrhea due to giardia. Immunologic studies are done. Results show that peripheral leukocytes express both CD3 and CD4 completely fail to express CD40 ligand. Based on this finding, the immunoglobulin isotype that predominates in this patient's serum most likely has which of the following biologic properties. So this started as a microbiology question and then quickly became an immunology question. Right? This guy doesn't have the CD40 ligand. Now you need to remember, what does CD40 ligand do and what is it all used for? So without CD40 ligand, the activated helper T cells cannot release cytokines for Ig class switching. Okay, and then you have to remember hot T-bone steak, and remember that interleukin 4 was to class switch into IgE, interleukin 5 was to class switch into IgA, right? But this patient will only have IgM. Remember that, and then that should ring a bell for MDs, right? MDs or MGs is how you have to remember it for this concept. MGs fix complaints. Medical graduates fix complaints. So IgM and IgG can fix complement. All right, and you look at all your answer choices, and the only one that works for IgM is D, complement activation. That's it. It was a very easy question if you remembered all of that, but if you don't, then you're just like, what's happening here? And you're pretty lost at that point. Okay, so IgM cannot cross the placenta, so A actually hints at a right answer, right? And the right answer was related to the IgG, which this patient would have. This patient is going to have IgG. IgG is the one that's going to fix complement. Right, complement activation. So, interesting way to test someone on that topic, but not too bad at all. 169, a 45-year-old man comes to the physician for a follow-up exam 1 week after he underwent an emergency appendectomy. Physical exam shows mild scleral icterus and well-healing surgical incision. Hemoglobin is low. His indirect bilirubin is much higher than it should be. Liver enzymes look okay. Which of the following best explains these findings? So look, he had a surgical procedure, and it looks like it all went just fine, but now he has some scleral icterus, he has some elevated indirect bilirubin. If your indirect bilirubin is not becoming direct bilirubin, there's only one of two real possible reasons. Either because you don't have the enzyme that does the conjugation, or you have some kind of inherent hemolysis, which is really making a lot of indirect bilirubin. Remember that bilirubin comes from heme. Heme becomes bilirubin, and if you have hemolysis, you have a lot of heme, so you're going to have a lot of indirect bilirubin. This patient definitely doesn't have hemolysis, so then the only other possible thing is that he has, for some reason, decreased activity of the conjugating enzyme. Look at all your answer choices, and the only answer choice that even mentions something about someone who would have decreased liver enzyme activity for conjugation is Gilbert syndrome. And then if you at all remember Gilbert syndrome, you'll be confidently picking it. Right, so 427, again from the easiest chapter of first aid, GIT, right? When you come to this page, you look at Gilbert. This is just a guy who went under some kind of surgery and then had some mild decreased activity of UDP glucoaminotransferase, mild conjugation impairment. So he's going to have some mild jaundice, but that's it, nothing else. His liver enzymes are perfectly fine because his liver is fine. Alright, so increase in unconjugated bilirubin without hemolysis. He had no reason for hemolysis in that question at all. He's just getting some normal response that can occur due to stress. Alright, this is a URO question on the same kind of thing. 21-year-old male presents to your office with mild jaundice after a hiking trip because he was very, very stressed. Right, stress or fasting. Right, similar episodes 2 years ago after fasting for 5 days. His physical exam is unremarkable. Everything's fine, lab is fine, but his indirect bilirubin is very high, direct is okay, alk-phos is okay, normal liver enzymes, everything's fine. It's just Gilbert syndrome. Crigler-Najjar is pretty bad, right? It's absent of that enzyme. You don't have it at all, right? So you get jaundice, kernicterus, very high unconjugated bilirubin. Some patients may not have neurologic signs until later in life. Really problematic. Treatment is plasmapheresis, does not conjugate UCB, but does increase polarity and increases water solubility to allow excretion. Very important to understand that. right? The plasmapheresis and phototherapy will not cause conjugation. It'll just make the bad stuff, the unconjugated bilirubin, into more water soluble so you can at least excrete it. But the only way to fix cranial nodule was liver transplant. Dubin-Johnson, right? You can just remember Magic Johnson. So Dubin-Johnson is actually just a black liver. Okay, it's just a black liver, but everything's okay. Everything's perfectly fine. You just have a black liver. The reason the liver is black is because you have estrogen metabolites that are just getting stuck there. Okay, so really important to remember that tiny fact. That was, sorry, not estrogen, my bad. Epinephrine metabolites. Tiny fact taught by this UWorld question right here. Right, so they told you that the liver appears black due to impaired excretion of epinephrine metabolites. So that's one more thing. And then Rotor syndrome. Rotor syndrome is similar to Dubin-Johnson, but the liver is not going to be black. Okay, and this image kind of tells you, like, yeah, 3 and 4 are due to intracellular transport, whereas 1 and 2 are due to the conjugation enzyme not working. Not so hard at all. Alright, this question was pretty easy because they only had one syndrome here. The other things would have different things, like liver failure would have elevated liver enzymes, hepatitis would have elevated liver enzymes, cholelithiasis is irrelevant to his issue, and surgical bile duct trauma is also irrelevant to his issue. Alright, 5 more questions, then I'll take a break. So let's see, 170, 4-month-old boy is brought to the emergency department because of a 1-day history of respiratory distress. His parents say that he has had progressive weakness and difficulty feeding during the past month. His respirations are 50 per minute. Physical exam shows an enlarged tongue and generalized hypotonia. Serum concentrations of lactate, pyruvate, glucose, and urate are within reference range. Chest x-ray shows cardiomegaly. Biopsy specimen shows increased glycogen in skeletal muscle. Which of the following enzymes is the most likely cause of abnormal glycogen storage? So this is the glycogen storage disease, right? 4-month-old boy. They gave you a lot of information to be able to knock out all your other answer choices, and you just come down to Pompe, right? Because he has high glycogen. So the only answer choice you could pick is he must not be making alpha-1,4-glucosidase, right? Pompe, remember the first and the fourth letter are both P, so 1,4-glucosidase. There will be no hypoglycemia, which is key compared to other glycogen disorders, right? They didn't tell you that the patient has hypoglycemia, right? He has hypotonia, but look at that. They tell you, this was the most important sentence here. Serum concentration of lactate, pyruvate, glucose, and urate are all normal. So he doesn't have hypoglycemia. The only glycogen storage disease with no hypoglycemia is Pompe. So you pick alpha-1,4-glucosidase and you're done. You will find glycogen in muscle biopsy and it stains PA as positive. Note hypotonia and hypertrophic cardiomyopathy as well as liver involvement. Liver enzymes will be high and CK will be super high. What about the other issues? So von Gierke is a deficiency of glucose 6-phosphatase. Glucose 6-phosphatase gets rid of the last phosphate so you can have free glucose. Without glucose 6-phosphatase, you will not have free glucose, so you note severe hypoglycemia. Gluconeogenesis and glycogenolysis are both impaired, so lactate and urate will also be high, and the urate causes gout in those patients. Okay, so that was glucose 6-phosphatase von Gierke. Branching enzyme actually makes the branches, so that's not relevant. And debranching enzyme, which is 1,6 and is not an answer choice here, debranching enzyme deficiency causes Cori disease, which is a mild form of von Gierke. Okay, the only last one was the McArdle, which would be, showing you myoglobinuria. That's not happening in this patient either. So that was it. Now, the only thing that's fucked up about this question is, with Pompe disease, you're supposed to die. The baby's supposed to die. The baby hasn't died yet, nor does the baby really look like it's, near death, but it probably will. I mean, history of respiratory distress in a 4-month-old baby is pretty sad. Okay, that's pretty problematic. And Pompe disease, the baby's not going to live. So it's alive so far, but not for long. 171, this was a question with an image that is not in first aid, nor are you required to know this image, but you should know what's happening in the patient based off of the history they gave you in this question. So 4-year-old boy is brought to the physician by his parents because of fatigue and irritability over the past 2 months. The family visited relatives in rural Louisiana 5 months ago where the patient ran around barefoot. That history is very critical. Ran around barefoot. The child is active and appears normal. Conjunctivitis are pale, so that's anemia. Lab studies include normal leukocyte with 15% eosinophils. Stool presentation shows this egg, and you're like, what the fuck is that? Which of the following is the most likely cause of fatigue and irritability in this patient? So you look at your answer choices, and this question became really easy because they're like, what causes fatigue and irritability? Well, anemia does, and that's just answer choice D. The other things wouldn't really cause fatigue and irritability. Myocarditis doesn't cause fatigue and irritability. That's just really annoying. Inflammation of your heart. Both ancylostoma and Necator have larvae that penetrate the skin and cause microcytic anemia by sucking blood from the intestinal wall. D was the only possible choice to cause fatigue anyway. Even if you had no idea what was happening, then the only answer choice to really pick was D, and then you move on. It could be wrong, it could be right, who knows? But at least you know for sure that microcytic anemia does cause fatigue. So ancylostoma and Necator, right? You see they don't give you a picture of the egg here. I put this picture here to show you that it penetrates your legs. So if you're walking around barefoot, you have to think of this patient, this kind of thing. Strongyloids also is larvae that penetrate skin, but that causes different things. Here in strongyloids, what happens is you get autoinfection, right? Larvae that penetrate your skin, go into your intestine, then you swallow it, right? You keep swallowing it yourself. It's really weird. You keep causing infection yourself, but you see, they don't really write much about what it's going to cause, right? It lives in you. Okay, it just lives in you. Strongyloids stricoralis just lives in you. Eggs and adult parasites seen in intestinal biopsy, right? But ancylostoma, they wrote here, it can cause microcytic anemia. Okay, so not bad. 172 was a question about vitamin D. Very, very straightforward. 5-year-old girl brought to the physician, increasing severe pain in her left leg one day after she fell off a sled. She recently came to USA from Iceland. She has a history of 3 bone fractures since birth. Parents are vegan and do not give the patient any dairy products. Okay, so no milk. Physical exam shows tenderness, swelling, and limited range of motion of the lower left extremity because she just broke it. An x-ray of the left lower extremity shows fracture of the fibula. Which of this patient most likely has a vitamin deficiency of which of the following? Vitamin deficiency that directly affects which of the following processes. So you already know from reading this that this is a vitamin D deficiency because it's related to bone. And vitamin D is necessary for calcium absorption. So C. That's it. Okay. A was here to make you think osteogenesis imperfecta, but that's not what we're seeing in this patient. Osteogenesis imperfecta would show up earlier, if anything. This is not a parathyroid hormone issue. Okay, so that's really all this is. 173, a 14-year-old girl is brought to the physician because of a 4-month history of heavy menstrual flow. Menarche occurred at the age of 13. Menses have occurred regular 30-day intervals. She has a history of frequent nosebleeds and easy bruisability. My bad. Her father has had problems with nosebleeds and clotting. Physical exam shows areas of mild gum bleeding and mild ecchymoses. So, reading all this, you're already diagnosing this, right? You already know this is von Willebrand disease. It's a girl. With females who have superficial bleeding, it's always von Willebrand disease, and it is autosomal dominant, so her father had it too. Hemophilia is going to have deeper bleeding, like hemarthrosis and stuff like that, and it's only going to be in the men, right? Because it's X-linked. So it's usually only going to be in men. You keep reading everything. Platelet count is normal, right? Bleeding time, whatever. PTT is high, 60 seconds, right? PTT. So PTT, remember, HTTP, heparin is part of the intrinsic pathway. It's related to factor 7. So that's that. Then they ask you which of the following is the most likely diagnosis. You didn't even need to know anything else because they actually directly put that as an answer choice. Von Willebrand disease, E. That's it. This patient has a normal platelet count but has a bleeding problem. Her PTT is elevated. HTTP and PIT remind you that PTT is related to heparin and the intrinsic pathway. Her defect is in platelet plug formation due to decreased platelet to von Willebrand factor adhesion. Right, so ristocetin assay would fail. The von Willebrand factor carries factor 8, or more like factor 8 carries von Willebrand factor, which ends up affecting PTT. It is autosomal dominant. Desmopressin is the treatment here, and that's really all there was to this question. Okay, so not that bad at all. Not that. Von Willebrand factor carries factor 8. Yeah, that's actually the correct way of putting it. Yeah, so pretty straightforward question. Last two. 174, 66-year-old man comes to the physician because of a 1-month history of non-productive cough and a 6-month history of progressive shortness of breath. He has no history of major medical illness. Bilateral and inspiratory crackles are heard. Heart sounds are normal. CT scan shows diffuse reticular opacities that are more pronounced at the periphery and bases of the lungs. Microscopic exam of a biopsy specimen shows patchy interstitial fibrosis and fibroblastic foci, but no granulomas. Which of the following is the most likely diagnosis? So, you look at your answer choices, and it was weird. When I was doing this question, I told myself, now I'm not really seeing any reason for him to have fibrosis, right? You can't see a reason. They didn't give you any kind of job history that can cause fibrosis. They didn't give you any kind of extensive smoking history, right? And it's a non-productive cause, so he's not sick. He doesn't have pneumonia that he's recovering from. There's no granulomas at all. And you can see granulomas, often things with the silicosis and stuff like that too. So immediately, since there's no reason being given and he has fibrosis, this is just idiopathic pulmonary fibrosis. Don't think too hard. Right? The way I read the question, they gave no reason for why he might have any of these issues. So I just chose idiopathic. And that was literally it. And then I checked and it was correct. This can occur from repeated cycles of lung injury and wound healing with more collagen deposition, leading to a honeycomb lung appearance and traction bronchiectasis at the end. So let's take a look at what that looks like. So honeycomb lung appearance is basically like this one right here. Okay, honeycomb lung appearance, and then the traction atelectasis they're talking about is the stuff at the end, the blue arrow right here. Not something crazy, right? Not something crazy. Really easy to understand. So right here, idiopathic pulmonary fibrosis. Right? You would also see clubbing because of hypoxia. Another topic that you want to make sure you remember is hypersensitivity pneumonitis, which is a mixed type 3, type 4 hypersensitivity due to environmental antigens. It presents very much like asthma, sort of, and it's often seen in farmers and those who are exposed to birds, anyone with birds as a pet. Right? It usually occurs because of something coming from the bird. So the only way to fix it is antigen avoidance. You got to get rid of those birds. Right? So a very important topic. They love talking about hypersensitivity pneumonitis because asthma is very, very high yield. And it's easy to make you think of asthma, even though this is not asthma. Right? When I do respiratory, I'm going to show you a bunch of practice questions we'll do. I've done them in my last videos as well. And it will really help you understand the difference between various restrictive lung diseases. You really need to master this stuff, right? All the pneumoconioses, sarcoidosis, all these are very high yield, and a lot of them have granulomas. So all those answer choices went away as soon as they said there was no granuloma. Right, so good stuff here, good stuff. We'll come back to all this when we do the normal lectures. Last question for this video. 98-year-old woman. This one I actually got wrong. So 98-year-old woman is brought to the physician for a routine exam. She has type 2 diabetes and hypertension. Current medications include atenolol, hydrochlorothiazide, metformin, glipizide. No chest pain or shortness of breath. Lives with her 75-year-old daughter and 50-year-old grandson. Okay, so she lives with these two. And she says that she is feeling fine. She walks 2 miles daily, does not drink alcohol or smoke cigarettes, has had 14-pound weight loss since her last visit 3 months ago, which is concerning. She is 5'2" and weighs 82 pounds, which is pretty low. Even for her height, you see BMI is very low, so these are looking a little concerning, right? And the physical exam shows multiple ecchymoses in various stages of healing on the upper extremities and torso, which is also pretty concerning. While assessing this patient's condition, it is most appropriate for the physician to ask which of the following. And, all of these are fine questions to ask, but the most important question, not even just most appropriate, the most important question to ask her was to ask her, are you safe at home? Right? Because elder abuse is a thing. I had the wrong mental map as I was reading this question. So my thinking was she's losing weight, so maybe she's been having diarrhea, right? Could also be constipation, which can cause her to eat less. So I was going to put B, right? Are you noticing any change in your stools? That was the answer choice I was going to put, right? And that was the wrong answer. I mean, that is what I put. I chose, are you noticing any change in your stools? I was thinking more along the lines of how old she is and colon cancer and stuff like that. So maybe she has polyps, maybe she has constipation or diarrhea. Either way, both things can cause you to lose weight. Constipation causes you to eat less, diarrhea causes you to lose everything. She already says she's feeling fine, and she's living with really grown-up people. 75-year-old daughter, 50-year-old grandson. These aren't really people you usually think will cause elder abuse, but they can. They totally can. A 75-year-old daughter who hated her mom her whole life will definitely cause elder abuse. A 50-year-old grandson who maybe hated his grandma his whole life will definitely cause elder abuse, right? So anything can happen. My thinking was those adults are way too grown for that kind of abuse, and I was really worn out. But the truth of the matter is anyone can cause abuse, so you never know. Right? The ecchymosis at various stages of healing were a key finding that really should have made you think elder abuse. Okay? And not to say that she doesn't actually, maybe she doesn't get any elder abuse at all. She's just not eating much and she's losing weight and she walks a lot. And, everything might be okay. But it's very important to ask, are you safe at home? And you can't ask a lead-on question. You can't be like, has your daughter been abusing you? Has your grandson been abusing you? You can't say something stupid like that. Just straightforward. Open-end question. Are you safe at home? Okay? But I went with B. Are you noticing any changes in your stool? Which, again, fine question to ask, important question to ask, but not the most important, given the way this question was presented with her concerning weight loss and concerning ecchymoses at various stages of healing. Okay? So that's it for now. I will actually be back. I'll be back in like 10 minutes. I'm just going to eat and come right back, and I'll finish up the rest of these questions. So we'll continue from 176 to 200, and finally end NBME 18. Alright, so thank you very much for watching. I shall be back in like 10 minutes.